say platelets, they are sign of this megakaryopoiesis. On the megakaryocytes, you will see hypogranular megakaryocytes. Normally the megakaryocytes cytoplasm is quite granular, similar to like a platelet. Or the macrocytes are monolobated. Normally the macrocytes have lobulated large nucleus, whereas here you find the only single nucleus in the macrocyte. Or micromacrocytes, or the macrocyte with all nuclei are like separated nuclei, like multiple balls lying inside the cytoplasm. That's also again a feature of this megakaryopoiesis. Coming to individual ones, what we call the myelodysplasia syndrome, refractory anemia, the peripheral smear, there is less than 1% blasts, and bone marrow, majority of them have erythroid dysplasia, and the blasts are less than 5%. And if you do an iron staining of the bone marrow with Prussian blue, you would demonstrate less than 15% ring sideroblasts. So that's the diagnostic criteria for the refractory anemia. Usually there is, as I said, there is erythroid component is commonly affected, and dyserythropoiesis is not necessarily always very florid, usually it is mild, and megaloblastic maturation is quite common. As I said earlier, it may not involve all the stages of erythroid cells, but only small population of cells, and they do not respond to B12 folate. This is just in the case of refractory anemia. They are showing that the pseudopelgar-weight neutrophil in the peripheral smear, there two of them are there, who is showing the hyposegmentation of the neutrophils. In the bone marrow, there is you can see many erythroid cells, but the arrow I have demonstrated one showing the binucleated nucleus in the reds in the early erythroid cell, and showing that is a sign of this erythropoiesis. And the bone biopsy can be this case is showing the increased bone marrow cellularity, and there is erythroid hyperplasia with many areas showing the dark blue nucleus, that is those are the erythroid cells. In contrast to the diagnosis of refractory anemia MDS-RA, the MDS-RA-RS has similar pictures. Again, it is in the peripheral blood less than 1% blast, and the bone marrow usually has erythroid hyperplasia with dysplasia, and the blasts are less than 5%. But the most important thing is if the iron staining shows more than 15% ring sideroblasts. So that's the diagnosis, that makes the diagnosis of MDS-RA-RS. This is the bone marrow showing many erythroid component. So the ME ratio in this marrow was 1:1, 50-50, and iron stain shows quite increased iron in this area. And here you can see the individual the erythroid precursors which are showing the ring form of siderotic granules in the erythroid cells. So those are the ring sideroblasts. You can see most of the erythroid precursors in the bone marrow are showing these rings, and so the ring sideroblasts are present, and present more than 15% in number. So that makes the diagnosis. This is then biopsy of the same patient. It's showing you can see again there is erythroid hyperplasia, and the center what you are seeing is the erythroid precursors. They are really much open chromatin. They are the erythroblast cells. So that will of course you will see in situations where there is erythroid hyperplasia. The 5q minor syndrome is again there is anemia, and most of the patients there is severe anemia, and they are morphologically macrocytic. You can again the blasts are less than 5% in the peripheral blood, and the important feature, another important feature is there is increased platelet count in about 50% of these patients. And if you go to the bone marrow, again there is megakaryocytic hyperplasia as well as dysplasia. Blasts are less in number. Sometimes even you can find there is erythroblastopenia. In most of the conditions of the MDS, you do not find the blast. Usually you find the erythroid component increase, but here is one condition, the 5q minor syndrome is one category of MDS where one can find erythroblastopenia. And the chromosomal study demonstrates there is isolated deletion 5q. It's a severe anemia needing transfusion, but otherwise it is patients have a stable course and they are of good prognosis. The one should keep, when looking for a diagnosis of 5q, one should keep two things also in mind. One is should not confuse with essential thrombocythemia. There also you get high increased platelet count and increased megakaryocyte number. The another one is a megaloblastic anemia, where again some particularly the treated patients of megaloblastic anemia, there is thrombocytosis and there is also increased number of megakaryocytes in the bone marrow. So one should keep all those in mind as well. This 5q minor syndrome, one patient, the peripheral smear showing normal platelet count, some macrocytes and macrovalocytes, and bone marrow, you see the monolobated megakaryocyte. This is a sign of dysmegakaryosis. The bone biopsy, you can demonstrate so many megakaryocytes, and most of them are dysplastic and monolobated. The next coming to another category, the MDS RCMD. The other one is called MDS RCMD RS. The RCMD refractory cytopenia with multilineage dysplasia, and some of them may be associated with ring sideroblasts. So RCMD RS. Here the cytopenia should be there in more than 2 cell lines. The peripheral smear blasts are less. Again the bone marrow also, the dysplasia in more than 2 cell lines, and blasts also less. You can see the dysplasia in the center. You can see the dysplastic erythroid with karyorhexis, and also some degranulated myeloid cells, the agranular myeloid cells, that sign of dysgranulopoiesis. Here you can see a binucleated myelocyte, again sign of dysplasia. The bone biopsy is showing a lot of megakaryocyte. There is again some of them are dysplastic. So there is both tricytopenia was there. Another subcategory is the MDS RAB and RAB2. This subcategory, the important one is the number of blasts. Here the blast number has increased in the bone marrow more than 5%. If it is 5 to 9%, it is RAB1. If it is 10 to 19%, is RAB2. Some of them even have OR rods in the blasts. Like here you can see the dysmyelopoietic cells with degranulated myeloid cells. This slide showing the increased blasts, which are important for diagnosis of RAB in an MDS patient. MDS unclassified, which as I said, if you cannot categorize into any of these subcategories and there is no increase in blast, they will be classified as unclassified. Like this one patient with thrombocytopenia, showing the dysplastic macrocyte with the separated nuclei. This is a sign of dysmegakaryosis. lipoisis. Here again in the same patient you can see so many macrocytes, and most of them are dysplastic macrocytes, agranular, they are either monolobated or separated nuclei. I conclude, the refractory anemia are a group of disorders called myelodysplasia syndrome, and the diagnosis is based on exclusion of all other causes. All other causes of refractory anemias like refractory iron deficiency anemia, sideroblastic anemia, refractory megaloblastic anemia should be also kept in mind, because those are more commoner than the MDS category. Thank you.
Very well described, Dr. Pati, I must say. But a few more questions, please. Can I ask you?
Yes, can go ahead.
Yeah, Dr. Pati, what is common subtype of refractory anemia?
The refractory anemia itself, as I said, the myelodysplastic group is a rare subgroup. But if you go among them, then by the WHO category, we find that the refractory anemia subcategory and the RCMD, they are the commonest subgroup.
And what are its diagnostic features?
As I said, the diagnosis one is by exclusion. The other one, I said, because there is no specific marker, like a chromosomal marker or any serological marker, so the diagnosis based on really morphology. That is the bone marrow examination to find whether there is dysplasia is present, and second there is increased number of blasts, and second another one is a chromosomal study also is another one which is important and should be done in all patients, because these are the minimal criteria needed. But as I said, I must stress the most important one as I remains is the cytopenia of unexplained and sustained. Sustained means more than 6 months, therefore one should not try to make a diagnosis if it is in early stage in the before 6 months time, and if inadequate investigations are done to exclude all other causes. Therefore, a follow-up and further investigations and from bone marrow, if needed, maybe a repeat bone marrow after a follow-up period are needed for a clear diagnosis.
So what is the role of bone marrow biopsy and bone marrow aspirates in the diagnosis?
As I said, the bone marrow aspirate is important for demonstrating different cell line morphology like dysplastic erythroid cells, the dysplastic macrocytes, or dysplasia in the granulocytic component. The features already we have said, the granulocytic component, the agranular, or if there is megaloblastic maturation, there remains important. The erythroid component, the nuclear changes, look for the nuclear changes, look for the developmental, the maturation asynchrony between the cytoplasm and the nucleus, whether there is any megaloblastic maturation in the erythroid cells, those are important. So coming to the bone biopsy, though bone biopsy is not not diagnostic in many situations, but many informations one can get from the bone biopsy, which we may not get from the bone marrow aspirate. Like for example, macrocytic dysplasia. Macrocyte is known to be less in number in the bone marrow. It is just less than 1% of cells. So if you are looking for dysplasia in less than 10%, more than 10% cells, so you have to search the macrocyte. Whereas in a biopsy, you can see the dysplasia much easier. The another thing of helps in diagnosis is called the ALIP. You can demonstrate the abnormal localization of the immature cells. So that's again only possible in the bone biopsy, not in aspirate.
So that was all for the second session of today's teleconferencing program, which was about refractory